also thank Chiro. Let me also thank Chiromo for being one of our partners in the same journey. We know that mental health is a challenge that has increased and become more synonymous with our changing lifestyles and changes in the profession. Since COVID, there's been a growing legal awareness that mental health continues to be a challenge. It continues to increase and it continues to incapacitate many of our colleagues. Of course, there's also a stigma related to mental health issues. There's the difficulty of engaging with someone who suffers from mental health and how to deal with them. There's a lack of awareness from many of us. We notice in the group sometimes some situations arise. We then make a joke of it, or we encourage, or we don't empathize enough the situation as it is. We also know that the mental health sector in Kenya has been severely neglected over many decades, and there's very little support and help in this sector. So we really felt it was critical that we started doing some work in the sector. And this webinar is the second on this area. And we hope it's beneficial to members. Feel free to, of course, engage with us or engage with myself or any board members or our secretariat on any ideas or future topics that you want us to cover. It's increasingly important, especially in this virtual world we live in, that we start to find solutions to mental health and also try and find support networks. We no longer have these support networks because we live in these little boxes we call offices, just attend court virtually. We don't really socialize like we used to just 4 or 5 years ago. At this point, I will stop. I will hand it over to Linda again. Linda, let me hand it over to you. We look forward to an engaging session. We hope to learn a lot. And of course, the members, please feel free to encourage others to join. We only have 67 members online. I really think we need a lot more to join us. You can see many of you from across the country. I see Rose Ngeche, Rosemary Opio, Rika Victoria, Trisha Wamboy, Roki Karanjak, welcome. So, Linda, all yours. Thank you very much, and let's have a great session.
Okay, thank you so much for the go-ahead. Yes, we are sharing the webinar link so more and more people can join us. As we join, we can continue. I don't know if you have another representative from ABA. Okay, now we'd like to go to the meat of the webinar, the main reason why we've joined this webinar. I know you are eager to hear and to learn and to understand about bipolar mood disorder. I'd like to introduce our speaker for the afternoon, Miss Victoria Rika. She's here with us. Rika is the head of corporate mental health and wellness programs at Chiromo Hospital Group. She has vast experience working as a counseling and clinical psychologist, and is also a core resource in implementing of the Employee Assistance Program, PAPs, for various organizations. With her expertise, she also volunteers as a youth and peer counselor. Rika has a master's degree in counseling psychology, youth and adolescent, and an advanced diploma in mental health practice from Amaref International University. The floor is yours, Victoria Rika, Head of Corporate and Mental Health and Wellness Program. Karibu sana.
Thank you, Linda. I'm very happy to be here. I am a clinical psychologist practicing at Chiromo Hospital Group, and if you'll allow me, I can share the slides, then we can proceed. Linda, confirm that you can see the slides and that they are moving.
Confirmed.
All right. Okay, thank you. So our topic today, in recognition of World Bipolar Day, which falls on the 30th of March, will be understanding bipolar disorder. And we also want to talk about the stigma and also raising awareness. So in passing, the vision of World Bipolar Day is simply to bring world awareness to bipolar disorders and therefore also eliminate social stigma. There's still a lot of stigma where mental health is concerned. So it's not just about bipolar, which is stigmatized, but there's a lot of stigma around any mental illnesses. But we will see how do we break free from the stigma. So for those who do not know Chiromo Hospital Group, those are our branches. I sit at the Upper Hill Medical Center where we run a wellness clinic, mainly seeing outpatients. So we're on that floor at Upper Hill Medical Center, and those are the rest of the branches in Lavington, one in Westlands, and one in Nyali, Mombasa. Our vision as Chiromo Hospital Group is simply to provide dignified quality mental health care, not just in Nairobi, Kenya, but in the regions beyond Africa. And our mission is to pursue excellence in the delivery of mental health services by using what we have seen to work, what we call tried and tested or evidence-based practices. Those are our core values: respect, honesty, innovation, and reliability. And again, to speak to the space of stigma surrounding mental health, our tagline is recovery in dignity. We've all seen patients, whether in documentaries or in real life, patients who are going through mental illnesses. We've seen the kind of treatment that they get. And we aspire within the Chiromo space to treat all our clients experiencing poor mental health with dignity. To start us off, we'll not read line by line, but we'll simply look at the highlights. These are the key statistics where bipolar disorder is concerned. 2.8% of the global population, that's approximately 46 million people worldwide living with the condition. Now, if someone is experiencing these mental illnesses, then their life expectation then goes down. They're 10 to 20 times more likely to die by suicide than the general population. And this could happen in one of the phases that we will look at. So at least 25 to 50% of individuals who are experiencing this particular illness will attempt suicide at least once in their lifetime, and at least 5 to 20% have completed or succeeded in the attempt. Again, there's what we call comorbidity. So I may have depression, and alongside depression, I may also have alcohol use disorder. We call that a comorbidity or a co-occurring mental disorder. So when you're suffering from bipolar disorder, about 60% of the population may also have anxiety disorder or another mental illness. Again, people or clients or patients experiencing mental illnesses to do with bipolar disorder, about 30 to 50% will have substance abuse issues at some point in their lives. And only 40 to 50%, which is a low number of anyone suffering from this illness, will receive treatment during their lifetime. So what really is bipolar disorder? And we've had this word thrown about and misused, because someone will say, my boss is so bipolar. Why? Because sometimes they're happy and they'll allow you to go for that leave. Other times they'll say, no, you cannot even take an off. So they describe you as being bipolar. But we realize it is a very serious mental health condition. And the difference between the moods that you will get when you're experiencing bipolar is what tells us the extremity. How extreme are those mood swings? You may be very happy, you may be very sad, but you could experience, now to put the academic definition of bipolar disorder, when you're having emotional highs, and we call this mania. If you have a lower version of what we're calling mania, then you'll be experiencing hypomania, or you may be having lows, which are now referred to as depression. Why it's called bipolar, it's because it has two polarities or two ends of the same. If you're holding a stick, you have two ends and they are different polarities. So one is very high, the other one is very low, and there is what we call the in-between. So people who are experiencing bipolar, their moods, which are either high or low, differ from what the people who may call themselves as having normal moods. The extremities will be different. It can, of course, interfere, as do all mental illnesses, with significant relationships in your life, with your work, and definitely with your overall quality of life. Now, the thing with bipolar disorder, in categories of mental illnesses, we say it is manageable with treatment, but it is a lifelong condition whereby you will need to take medication, you will need to go for therapy, and you'll need to adhere to the treatment regimen, which is a combination of the medication that you will be given, as well as the therapy sessions on how to manage the condition, for the family, how to support an individual. But basically, it is a lifelong condition. So, as with many illnesses, not just mental illnesses, people experience bipolar differently. But in a nutshell, they may follow 3 stages. And we have the first stage, which is the prodromal stage or the early stage, before the client or the patient gets into a phase. They may notice some small shifts in their mood, their behavior, or function, especially if they have been diagnosed. Then they can tell that an episode is coming, and either they will take themselves to a medical facility or they will take the medication if they have not been taking the medication. So there's that early phase or that early stage where they may notice now, or the people around them will notice, that their mood has changed, their behavior has changed, their functioning does not necessarily go down. It could also become, they could actually be very productive because they could be experiencing the beginning of a manic phase. Then now we have what we call the acute stage. This is where now the mood is at its highest. There's a full mood episode. Now, remember, we have different types of bipolar, and we will discuss that. So the mood could be manifesting itself as mania or depression, or they could be having a mixed episode. Now, depending on what they have been diagnosed with, if they have been diagnosed. Then we have the third stage, which we call the maintenance stage. And this is now about managing the disorder. And how do you manage it? Again, from person to person, through medication and therapy. So the typical onset of bipolar is usually around 25 years. Now, this is not cast in stone because most mental illnesses begin around the age of 14 years, but they go undiagnosed. And then around the age of 24 years, when the symptoms start impairing the quality of life of this particular person, then they go for a diagnosis and they realize that these symptoms this person has been experiencing are actually symptoms of bipolar depression or whatever illness, because we have most mental illnesses being diagnosed from as early as the age of 14, in some instances even below, but a general age would be about 14 years. But for bipolar, many will receive a diagnosis around the age of 25. Then there's also what we call the late onset of bipolar, which is around the age of 50 years, and that could also now be as a result also of another medical condition. So there are very many myths going around where bipolar is concerned, and you already mentioned that from the beginning, if you're someone who is prone to mood swings, you're already called bipolar even without a clinical diagnosis. So people will say that if you have bipolar disorder, you're just being moody. But the fact is that it is a serious medical condition requiring treatment. Manic episodes sometimes can be said to be fun and productive. And if you come across a client who is experiencing a manic phase, they may be very productive, but there's a limit to it. So the mania could also lead to dangerous behaviors and severe consequences. So it's actually a myth that they're just all fun and productivity, whereas there's some truth in that. But the fact is that it can be a dangerous period if it is not checked. Again, there's a myth that bipolar disorder is rare, but the fact is that it affects millions worldwide, like we've already seen, about 46 million globally. Now, another myth is that if we talk about having bipolar and we are saying that it's on two polarities, so you're either very depressed or very manic, but there's what we call periods of stability where many individuals having bipolar will be having a lot of stability. They will be what we would call normal, as normal as the next person in between episodes. As long as they're taking their medication, as long as they're doing their therapy, then they should live a life that is relatively normal. And when they're able to pick up on the symptoms before they have a fully blown episode. Again, a myth is that bipolar disorder is the same for everyone, but we already mentioned that it manifests differently in each individual. So you could have bipolar 1, you could have bipolar 2, you could also have what we are calling cyclothymic bipolar, but we will define that. So you will have symptoms when you're having a depressive episode of bipolar disorder. Now, the interesting thing is bipolar 2, which will have more of a depressive episode, unless I sit with a family member or you're lucid enough in a session to tell me that sometimes I feel low and other times I feel very high. I feel like I want to go to town, I want to do shopping, I want to do a project, I want to do so many things at the same time. You could easily be diagnosed, or may we say misdiagnosed, with major depressive disorder, which is why it is very important, if you're having symptoms, to come with a family member or to have the insight to tell your physician or your therapist that sometimes, yes, I do have those depressive symptoms, but then again, there are times when I feel very active. I can hardly get enough sleep. I want to do risky things. I'm having a lot of hypersexuality. So when you put the two together, then you can easily diagnose that this person is actually having bipolar disorder. So if you are having a depressive episode, then you'll have the typical symptoms of clinical depression, which are feeling very down or sad or anxious. Sometimes you're feeling sad, you can't quite explain why you're feeling sad. You feel slowed down or restless, you're feeling lethargic. Sometimes you may have what we call insomnia, you're not having enough sleep. Or again, on the flip side, you may then have what we call hypersomnia. You find yourself sleeping for up to 10 hours. And there's no justifiable reason as to why you're sleeping. You didn't work late, you didn't travel, you just find yourself sleeping more than the necessary 7 to 8 hours. Again, you may find yourself having difficulty because your cognitive function is impaired, then you have problems with your memory, you have trouble concentrating, you're making poor judgments, or even having trouble making decisions. Sometimes you may feel that very impaired, you're unable to do even simple things, get out of bed, take a shower. So these are the classical symptoms of a depressive episode of bipolar disorder. But remember, we must put all these symptoms into some sort of criteria for us to say that, yes, you're experiencing the symptoms of a depressive episode of bipolar disorder. Now, if you're having a manic episode, and manic episode now goes with bipolar 1 disorder. Now, you may feel very elated or extremely irritable. Like if you are to light a match on someone who is going through a manic episode, they would simply light up like they're on fire, like someone has poured petroleum on them. Why? Because it is a period where they're very highly wired. They're talking fast about a lot of different things, and that's what we call flight of ideas. They're talking about how I need to do this project. I'm going to wake up tomorrow morning. I have so much money in the bank. I'm going to dispense part of it. And they have a lot of ideas. And if you're not aware of this kind of a symptom, tomorrow you come and you're also worked up because your boss said that you're going to do this kind of a project. And when you come in the morning, now again, they have experienced a depressive episode. So you're there talking about what they discussed yesterday, and they're wondering, what exactly are you talking about? They do not even have the energy. So when you're having a manic episode, again, you may have very impulsive or risky behavior where things like hypersexuality come in. You get into multiple sexual relationships, or someone just jumps into a car and says, I'm driving to a particular place. So all these symptoms put together, again, are what we call common symptoms of mania in bipolar disorder. So the several types of bipolar are bipolar 1, where you've had at least one manic episode, which may come before or after hypomanic. Now, hypomania is simply the lower version of having a manic episode. So we have mania, which is very high. Then we have hypomania, which is a lower version. Don't focus too much on the terms. You may get lost in all of it. Myself, I do get lost in all of it, but it is important to catch what really is bipolar by definition and what are the symptoms. So in some cases, you may also have what we call psychosis in bipolar 1. And even in bipolar 2, you could also have psychosis. And psychosis means you're out of touch with reality. So you may see someone talking to things or images which are not there, hearing voices which no one else is hearing. And those are things that we may refer to as hallucinations or even delusions, where you firmly believe something which is not true. Then we also now have bipolar 2 disorder. Now, bipolar 2 disorder means that you've had at least one major depressive episode, as we have defined, and at least one hypomanic episode. Remember, we said hypomanic is a lower version of a manic episode. But in bipolar 2 disorder, you've never had a manic episode, but you've had hypomanic episode. Then we have the third type of bipolar, which is called cyclothymia. So this is more where you've had at least 2 years or maybe 1 year, where children and teenagers are concerned. You've had many periods of hypomania symptoms, which are more depressive, and these symptoms are less severe than major depression. Then the final one is called mixed episode, where we have bipolar and related disorders, but this could be caused by maybe a medical condition, maybe by alcohol, and these also include mania or hypomania. So we can see them there: bipolar 1, bipolar 2, and also cyclothymia. What could be missing there is what we call the mixed episodes. So you can see with bipolar 1, there is that very manic phase. So you're up there. You are irritable, you are spending. If you have money, you go to a hotel, you pay money, you go shopping, you do things which ordinarily you would not do, and you're doing it on extremities. So bipolar 2, same symptoms but lower. So you have what we call hypomania. And then we have cyclothymia, which is now over a longer period of time. So when you're having, for example, bipolar 1 disorder, because we said that you need to put the symptoms together to come up with a diagnosis, you have one manic episode lasting at least 7 days or requiring hospitalization. Now, with bipolar 1 disorder, the mood shifts are very, very dramatic, very extreme, and will affect your daily life and relationships. For example, you may find a person who is going through bipolar 1 experiencing a week of high energy, reckless spending. They will send you money and you'll be thinking that they're being generous. They have no sleep at all. They will go for 3 nights without any ounce of sleep, but then it is followed by severe depression, which will last weeks or months. So if we put all this together with other symptoms, then we're likely to diagnose bipolar 1 disorder. Bipolar 2, at least one hypomanic episode, which again we are saying is a milder form of mania, and then at least one major depressive episode, lasting at least 2 weeks, which is now again the same diagnosis for clinical depression. So I'm saying that when you're trying to diagnose bipolar, sometimes it is on a very thin line, trying to balance between, is this person experiencing major depressive disorder or are they experiencing bipolar? Which is why we say if the patient is not well enough to speak to us and tell us their symptoms, then the family member, the co-workers, or people in the environment come in very handy, because they're able to tell us the two states of this particular person. So if you look at the example, a person may feel highly productive and energetic for just a few days, which is hypomania, and then you have a lot of intense sadness and fatigue that follows for weeks, which is now the depressive episode lasting for at least 2 weeks. Now, with cyclothymic disorder, these are chronic mood fluctuations. You know, over a period of time, you could have maybe 4 episodes within the 2 years. That's about 8 episodes, so on. Then these ones, the symptoms or the periods of hypomanic and depressive symptoms will not fall into the criteria for bipolar 1 or bipolar 2. And the moods are not as severe in any of the other bipolar types. So what are we saying? We are saying that this person may have mild highs and lows, but their symptoms are not severe enough to be diagnosed either with bipolar 1 or bipolar 2. So we call it cyclothymic disorder. Mixed episodes, you know, is what you might expect present a combination of these other symptoms. So now when you're having a mixed episode, the person will experience mania, hypomania, depression simultaneously, which sounds kind of, worse than being diagnosed with either of the other ones. But really, unless you're the person experiencing it, then you may not be in a place to say for sure what someone is going through as a patient. So what are the causes and risk factors? When it comes to mental illnesses, we say that the factors are multifactorial. There are very many factors that can cause mental illnesses, whether it be depression, whether it be post-traumatic stress disorder. But bipolar disorder, the real cause would say the research is still ongoing, but it appears that there's an interaction of genetic, epigenetic, neurochemical, environmental factors. So heritability, which is now the genetic predisposition, is very, very well established. Now, if, for example, your parent has bipolar depression, then you as an offspring may develop bipolar disorder. We say what you have is what we call a predisposition or a likelihood, not necessarily to say 100% that you must get bipolar disorder, but you have a higher likelihood as opposed to someone who has got no bipolar disorder in the family history. Now, when we talk about predisposition, we are simply saying the likelihood. So if, for example, you have hypertension or diabetes in the family, when you come to a clinician, the first thing they'll ask you when you talk about the symptoms, do you have someone in the family who has hypertension or who has diabetes? It is the same thing. If you present with those symptoms or you're brought by a family member with those symptoms, then we'll be inclined to ask you about the family history. Then there are also environmental factors, things like childhood maltreatment, particularly where there was emotional abuse or neglect, has also been linked to the later development of bipolar. Then other stressful life events, for example, things like divorce, things like unemployment, things like disability, and even early parental loss has also been seen to trigger bipolar disorder. Stressful life events, all these things, and even substance use, sleep disruptions, these are things that could cause or could trigger bipolar disorder. Remember, sometimes you may have a mental illness which is in you potentially, and then it takes a stressful life event to bring it out. Remember, the numbers are very high. We say that at least 4 people will experience or are currently experiencing a mental health disorder. So what are the effects of bipolar disorder, whichever type? Well, the severity depends again, if you're having bipolar disorder 1, the impact may kind of be a little bit much more because you're given to doing more risky things than someone who has bipolar 2. But generally, if you have bipolar disorder, there'll be strained relationships because people don't understand you. Today you're happy, tomorrow you're not happy. One day you're giving out things, the next day you're very mean. So people don't understand you. You may have very strained interpersonal relationships. Remember, when you're having manic episodes, you are kind of not yourself. So you're doing things which ordinarily you would not be doing. So once you come back to yourself, a lot of guilt and regret over things that you have done. You'll feel ashamed of depressive episodes. Depressive episodes can be very debilitating. You want to stay in bed, you don't want to wake up, you feel you don't want to be in any social circle, maybe when your eating patterns change, because sometimes you'll find yourself binging on high-calorie foods like cakes and biscuits and what have you. Other times you may feel you have no appetite at all. You may also feel very sad, very hopeless, very helpless, and those depressive episodes can take you to a place where you start trying to cope maladaptively by using things like alcohol or marijuana. So again, when you're having bipolar, difficulty maintaining a job or studies, that is pretty self-explanatory. Then there's a lot of stigma and discrimination. Remember, you're out of yourself when you're doing the things that you may do when you're having an episode. But what do people look at you and say? This person has lost it. This person is not normal. So a lot of stigma and discrimination. We've already mentioned increased risk of substance use, suicidal thoughts, and all these other things. You struggle with your identity and stability. Really, who am I? Do I define myself as a bipolar? Do I define myself as someone who's experiencing bipolar disorder? Who really am I away from the mental illness? And of course, there's the issue of sleep disturbances. And then again, financial instability, which now comes with a whole lot of other things. Because when you're having a manic episode, one of the things that we've noted bipolar patients to do is to really spend and spend and spend endlessly. So what are the challenges of managing bipolar disorder? Number one, It's not even difficulty accepting the diagnosis. It's actually difficulty getting the correct diagnosis. You need to go to a professional because we've already mentioned, if you come to the clinic and the only thing we are seeing is the depressive symptoms, then we could easily diagnose you with major depressive disorder. Again, if you come and you're having maybe a manic phase, then you could also easily be diagnosed with something like schizoaffective or schizophrenia, which are also illnesses which kind of mimic bipolar disorder. So difficulty in getting the correct diagnosis, and then also difficulty accepting diagnosis. Most of us do not accept diagnosis where our mental health is concerned. It is easier for someone to be told you have hypertension, you have diabetes, even cancer, than it is for someone to accept that I have a mental illness, because you look like a less human being. For some reason, the stigma there is very, very huge. Again, the challenges could be now managing co-occurring conditions. We mentioned comorbidities, which is where you may have depression, then you find yourself having alcohol use disorder. So as you're managing bipolar, then again, you need to manage anxiety or substance use disorders, which are other mental health issues. Balancing independence and seeking support. Sometimes when you're experiencing mental health issues, people look at you like you cannot manage. You come to the workplace and they've already labeled you. This one has bipolar, this one has depression. So they do not give you as harder tasks, if we may say, as they will give other people. If there's a traveling opportunity for a certain project, they may say, no, let her not go. You know, she has bipolar, she has depression. So you don't know, should I seek support from the organization or should I keep mum about my mental health? And then how do I seek support if I keep quiet about it? Potential risk for substance use, stigma, we've talked about that. But what is worse now than stigma, social stigma from the public, is self-stigma, where you look at yourself and internalize the negative information you have about the disorder you're experiencing. So you may look at yourself and then say, you know, have a pity party, and you're there talking about your inability to do 1, 2, 3. Why? Because I have bipolar, because I have depression. So you will not even talk about your condition because you're embarrassed to do so. So you do what we call self-stigma, and that is worse than even stigma from the public. Feelings of guilt, strained relationships, and then also impulsive spending. And there is the cost of treatment, especially if you do not have insurance. Lately, most insurance companies are taking care of people who are experiencing mental illnesses, bipolar included. But if you're paying cash, then it can be quite a stretch, as you may also need periods of hospitalization, especially when you're experiencing the manic or the depressive phase. So how do I live, you know, if I've been diagnosed with bipolar depression or bipolar disorder? Learn about your condition. Get as much information as you're able to, but of course, get it from the right sources. Learn about your condition, about your disorder, and then understand what it is that you are experiencing. We are very strong on preventive, protective, promotive measures where mental health illnesses are concerned. And sometimes we will tell you all the time, that some of these mental illnesses, like for example, the major depressive disorder, is preventable, because you may be having a situation and you already know you have a predisposition towards getting depressed. So what do? I do a lot of self-care. I go to the gym, I take care of myself, I eat well. And that way, even when there's a trigger, then I will not get depressed. But now, if you do not know about how to prevent those conditions, which are preventable, then it may be a little bit tricky. Bipolar condition may not be preventable, especially if it runs in the family history. But for those where you know that I can avoid substance use disorder, I can avoid depression, then it is important to learn about your condition. Take medication consistently. We've said that for you to treat bipolar disorder, then you need to take your medication. You also need to take your therapy seriously. Maintain a healthy daily routine. If you take medication and you're also involved in drugs and alcohol in the mix, then that would be a little bit tricky. A healthy daily routine means, you know, regular exercise. It means eating nutritious food. It means also avoiding drugs and alcohol, doing self-care, trying to manage things that will trigger you. If I am in a stressful environment, maybe a toxic work environment, maybe a bad relationship, it could be something that will potentially trigger me to an episode. Then I need to manage it before I get triggered. Then also build a support network. Social capital is very important. Who can you refer to? Do you have some friends? Do you have family? Do you have colleagues who you say are your social capital, who can come and stand with you in your time of need? And then again, keep in touch with your healthcare team. Now, what we have seen with bipolar disorder, especially for people who tend to be a little bit religious, is that they may abandon the medication and say that they will do prayer. And we are all for prayer of whatever religious leaning you have, as long as you take your conventional medication. So sometimes they will do away with the medication, and sometimes they will be recommended to do alternative medicine, things like supplements, but we always see them come back and have a very bad relapse. And the sad thing with mental illnesses is that when you have a relapse, it's usually worse than the initial phase where you became unwell. So it's important to keep in touch with your healthcare team, because then they will be able to help you with your medication and with your therapy and managing the symptoms. So how do you support someone with bipolar disorder? It could be a colleague, it could be a family member. Also educate yourself about the condition, not just about bipolar disorder. Educate yourself about mental health generally. Listen without judgment. It is very important that we do not judge, because as long as you've not been diagnosed with something, then you'll assume that you are okay. And we've already mentioned statistics are very high, that 4 people, will be diagnosed with a mental health condition. So it is important then to look at those statistics and listen without judgment, because you could fall in the category of the 4 who are experiencing poor mental health. Encourage professional treatment. Don't encourage someone who is taking medication to stop their medication, telling them that so and so use supplements, or they went to this herbalist and they got medication. Encourage them to continue with professional treatment, where they will adhere to the medication and also to their therapy. Then help them with routine and structure. Sometimes when you're experiencing poor mental health, it can be quite overwhelming. So how do I cope? I have a job, I have a family, I have work, I have school. How do I manage and not allow the stress of getting to balance work and life trigger me into a place where I have another episode? Then offer empathy. Empathy is simply stepping into their shoes and seeing the world from their world view. So offer empathy and understanding. Be patient, encourage treatment, and also self-care. So what should you avoid? Do not dismiss their feelings. Do not tell them that this is going to be, you're going to get through this, without listening to what they are trying to tell you. So listen to them. It is important, especially for people who are experiencing the depressive phase, to feel listened to. Part of the reason why suicide happens when you're depressed is because you feel no one understands me, no one is listening to me. And we know that 80% of people who die through suicide are usually clinically depressed. It is because of that feeling of hopelessness, that feeling of helplessness. And when you try to talk to someone, they dismiss you. And especially where the men are concerned, they will ask you, why can't you man up? Why can't you hold yourself together? So do not dismiss their feelings. Do not enable risky behavior. We've seen what could happen when someone is in a manic phase. They could be very, impulsive. They may get into risky sexual behavior. They could go to clubs and use drugs and substances. So do not enable the risky behavior. Again, if you're taking care, you're a caregiver of someone with poor mental health, don't neglect your own well-being. Because what happens is, if you neglect your own well-being, then usually you also become a patient. And we've all been to, we all know that, when you're in an aeroplane, you're told before you mask someone, first of all, put on your oxygen mask so that you're able to take care of someone else. So don't neglect your own well-being. That is quite important. Assuming all mood changes are due to the disorder is also something that you should avoid. Some of us, will tend to be moody. Women sometimes just before their cycle will tend to be very irritable. So don't tell a woman who is, going through normal phases in life, like even menopause or perimenopause or going through her regular cycle, don't tell her she's becoming so bipolar simply because her mood is changing, unless it is completely diagnosed. Trying to fix them, don't try to fix someone. Let the medication and the therapy and the support fix them. And then also don't ignore warning signs. There are all those subtle signs where you will see like someone is going towards an episode, and then don't use stigmatizing language. Don't label people and call them depressed or schizophrenic or bipolar. Use the correct language. And if someone near you is using stigmatizing language, then please educate them. So the sources of stigma as we wind up around bipolar disorder is misconception. A lot of lack of information is what gets people into a place where they're very, very, they stigmatize other people. If we look at the early days of when we had HIV, people believed that if you shared a cup, if you held hands with someone who was having HIV, then automatically you got infected. So there was a lot of stigma around that time. But now we know very well the causes of HIV and all that. So if we are able to understand the disorders, mental health issues, that mental health is not simply where you look like you're off, like you're collecting papers on the street. You can be having an office job, you can be a regular employee, and you have a mental illness which is not diagnosed, because you cannot just tell by looking at somebody that they have a mental illness unless they erupt or they have an episode. So it is important that you understand that people who have mental illnesses are actually the recipients of aggressive behavior rather than the perpetrators. People with bipolar are sometimes said to be violent, unpredictable, unstable. But even if you look in your local villages, in the market, look at how people who have poor mental health are treated. Some will, you'll see someone throwing a piece of bread at them, someone else is throwing water on them. So these people could actually be experiencing bipolar disorder, which has gone off because no one is taking care of them, but they are treated unwell. They're treated very unfairly by people because of that stigma. Again, self-stigma, we've said you'd rather have social stigma than self-stigma because you're internalizing those negative beliefs. You're believing what people say about people who have poor mental health. They're unstable, they're violent, they can't run a day job, they can't have a family, they can't marry, they can't get married. So you internalize those things, and then you start now living your life in that kind of a way, and to lead to a lot of shame, low self-esteem, and you will not be able to seek help. Workplace and social stigma. Studies show that 82% of workers who have a mental illness do not share their condition with their supervisors. Why? Because they're afraid of being stigmatized, being given lighter duties. But you may be surprised that you may share your condition or your mental health challenges in an enabling work environment where they support mental health, and you may get the relevant kind of support that you need to help with your mental health. So how do we combat stigma? Educate people, create awareness. Again, challenge stereotypes. I've already said if you come across someone using stigmatizing language, correct them. Encourage open discussions. Let us normalize the conversation around mental health. We talk a lot about our gynaes, our dentists, our cardiologists, but hardly do we talk about our psychiatrists and our psychologists. Why? Because there's so much stigma. If you tell someone I want to leave tomorrow to go and see my psychiatrist, they will look at you with a knowing look, like what exactly is going on with you. And then also advocate for policy changes, push for stronger mental health policies, and this is actually happening. Already we have the law about suicide being a criminal act. It was repealed, and now suicide is being treated as a mental health challenge, away from it being a criminal activity. So treatment approaches for bipolar, medication, psychotherapy, and then also lifestyle adjustments. So what do you do as an individual? Prioritize self-care. Take time out for yourself. Take regular breaks away from work. Do things which make you happy. If it is going to church or going to the mosque, going to Karura or wherever for a walk, going swimming, going to the gym, do things that prioritize your self-care. Also, social capital. Build very strong relationships. Manage stress effectively. Stress in itself does not cause you to have a mental illness. What will cause you to have a mental illness is chronic stress, which is not taken care of and which sets you to a place where you have where it triggers a mental illness. Engage in physical activity. Physical exercise is known to release endorphins, which improve your mental health. And then try and do what we call not work-life balance, but work-life integration. Spend so much time at work, spend so much time at home, spend so much time at the gym, spend so much time with your academics. If you're still doing your academics, do something to help you with work-life integration, and then seek professional help when needed. And when is that? When do I seek professional help? If the symptoms are persistent, I feel sad all the time, I have so much anxiety, I feel hopeless, I have a lot of intense emotional distress. Distress is the negative stress. Sometimes I find myself crying for no reason. I feel I have so much anger issues. I find myself panicking. If I go through a major life change or stressor, it could be a separation, it could be a divorce, it could be job loss or death of a loved one. Again, if you go through something traumatic, it could cause you to have to get triggered to an episode. Maybe an accident, maybe a natural disaster, maybe you are assaulted sexually or physically. And then if you have physical symptoms without a medical cause, you're always feeling tired, you have gastrointestinal issues, you have colds and flus, you've been to the hospital, there's no diagnosis, then you need to seek professional help with a mental health specialist. And then, of course, do what you call preventive care, seek a professional for wellness session as well as for personal growth. And with that very hurried session, I would like to hand it back to Linda for a wind up as in the interest of time. Thank you, Linda.
Thank you. Thank you very, very much. Let's take a few minutes to appreciate Miss Rika Victoria. Thank you. We appreciate how you've taken us through the slides and understanding and unmasking bipolar mood disorder. Thank you. So right now, we'd like to open the Q&A session. If you have any questions, kindly post them on the chat. Yes, at least we'll take a few minutes and hear a few questions. Karibuni.
Can I go ahead and ask?
Sure, go ahead.
All right. Thank you so much for the session. Indeed, very, very informative. Having gone through everything that we've had today, because I do have a son with the same condition, I'm just curious, and I think I want to pose this question to Chiromo. How well are you raising awareness in schools, especially within that age group that we've had today from 14 to 25, and not just for the students, but also for the teachers, because I've been a teacher and I have had a student with the same situations, but I didn't know. So how well is Chiromo taking it upon themselves to go out into the schools, talk to the students, and talk to the teachers? And when talking to the students, I'm also referring to areas of brain health and brain fitness in the area of avoiding drugs, because even from what was shared today, that drug-induced bipolar can be drug-induced depending on the environment. So how well is Chiromo taking this upon themselves? And if so, what is the progress? Thank you.
Thank you very much, Caroline, for that question. Now, as Chiromo Hospital Group, we do a lot of CSR, corporate social responsibility, and we go to churches, we go to schools, we go to mosques, wherever we are called, we come and create awareness. We have been to very many schools to create awareness on mental health in general, and we'll talk about things like bipolar, we'll talk about depression, we'll talk about ADHD, we'll talk about eating disorders, basically what concerns mental health, because we did say diagnosis start early. Even 14, even 12, you'll get children diagnosed, not diagnosed, they have mental health disorders which are not diagnosed, and the symptoms, sometimes the teachers pick up on them as probably a child who is very, misbehaved, a child who is very naughty, especially where ADHD is concerned. So we have been to very many schools, we've been creating awareness, but the flip side to this is that most schools, if I may say, because we've tried, or maybe, let me not say most, some of the schools do not realize the importance of mental health. And the interesting thing, Caroline, is that we do not charge for these CSR activities, especially where schools are concerned. The ones that we've made inroads, we've talked to the teachers and we've talked to the students in different categories. But then again, you'll realize that some of these schools, if not most of them, are the schools which have an international leaning. So for them, they've kind of realized that there's a very big gap where mental health issues are concerned. But we've also tried with some of our local schools, succeeded in some places, sent some proposals, and we are sending proposals as CSR, but the uptake has not been very good. The uptake in churches, in universities has also been good in colleges, but we are still trying to create an inroad where local schools are concerned. So if Caroline and others listening to me have got some contacts and you'd want us to speak to the children, to the teachers, we are more than willing to do that. And please remember, it is purely Chiromo sponsored, what we call CSR. We are quite big on that. I don't know if I've answered that, Caroline.
Yes, very, very well. And I think I will see how to help in that area.
Thank you. I'll post my number on the chat, so you can always text me or WhatsApp me, then I'll be glad to visit the schools that you will give me, some leads on. Thank you.
I have a question.
Yeah, go ahead, Grace.
Since we have seen the symptoms of bipolar, the causes, now what exactly tells that this is bipolar? Is it through assessment, like the way you can tell if the learner has autism, he or she must go through assessment, and then he or she can be diagnosed with autism. So what exactly tells that this is bipolar?
Thank you, Grace. So to find out if you have bipolar disorder, we do what we call evaluations. So we'll do a physical exam. So probably even some lab tests, because sometimes you could be having a medical condition which is causing your symptoms. So we want to clear that out of the way. Then we have mental health assessments, and we have standardized tests, mainly from the WHO, which tell us that if this person ticks this, and that together, then there's a leaning towards bipolar depression or bipolar disorder. So you will actually answer a series of questions, and also family members may be asked to provide information about your symptoms for us to get a correct diagnosis. Then there's something that we call mood chatting. Mood chatting is where we ask you to keep a daily record of your moods, things like sleep patterns or other factors that could help us make the right diagnosis and also get you the right treatment. So yes, Grace, that would be how we evaluate and finally conclude that this person indeed does have bipolar disorder.
Thank you so much.
Okay, we have a question on the chat from James. James is asking, what can one do when a patient resists medication and psychological support?
Now, this is quite an unfortunate kind of a scenario because for us to help a patient who is mentally unwell, we need them to have what we call insight. Insight means that, yes, I'm aware that I have depression. There's even evidence to that. I'm hardly going to work. I'm hardly getting out of bed. I need help. So you have insight. But for a patient to resist medication and to also resist psychological support means they are in denial. Because if the affordability is there, then the only thing which would tell us why this patient is refusing this is because they are in denial. And it is very hard to deal with a patient who has got no insight. Now, if a patient, for example, has a manic episode, you're not going to leave them to the elements. You'll not say because they have refused the support, then we leave them, we let them be. Now, what we do and what the law has allowed us to do is that you as a caregiver, you could be the spouse, you could be the parent, you could be whoever you are, how you're related to this person, is that you're allowed to do what we call involuntary admission. I think for about 72 hours, so that this patient can get the help that they require. But if this person is not manic, meaning you're able to reason with them, then the only thing that you can help them with is the support. Tell them that for sure, this illness has caused you some debilitating effects. You're not going to school, you're not going to work, maybe your marriage has broken down because of the condition of your mind. So show them things that actually real that the illness has caused them to have, and then support them and tell them that when you're ready, I will definitely go with you to see the professional. But if it is a place where even they are suicidal, they are spending, they are doing things which the manic phase is causing them to do, the depressive phase, then you can actually admit them involuntarily. As long as you're a family member, you can actually sign them in. And we've had patients who've been brought even by the workmates, then they send them in, and then later on we have now the family members come in and rubber stamp that signage. So you're able to help them now, well, I would say by force because it's involuntary, but it's usually for the best, because you don't want someone running around and they have a manic episode, because they will do a lot of damage to themselves and it's going to catch up with you as family members. I hope that's answered well.
Okay, thank you. We have another question or a concern from Deborah. She says, can you target universities and other institutions of higher learning because the feeling of hopelessness and depression are very common. Also, let me recommend Kabarak Primary and secondary school, they would greatly benefit from the training. I think that's more of a recommendation to you, Ms. Rika.
Thank you. We are willing, Linda, to go to these places, and it makes it easier for us if we have a contact or someone who can tell us, okay, fine, go and talk to this person, and then give them the proposal. Because, like I'm saying, sometimes funds could be limiting, but what my department, which is wellness, does is that we do CSR, creating awareness, letting people know there's help, there are resources. So if we can get contacts, we're all good to go. And not just schools, universities, but even churches. Basically, where there's an audience, then we are good to go. Thank you, Linda.
I think those are all the questions I've received so
Excuse,
far.
Linda.
Yes, yes.
Sorry to cut you short. I have a
Yes.
last one, a quick one.
Okay, go ahead.
I was able to hear Victoria mentioned around the workplace not being, for lack of a better word at the moment, being judgy towards the people who are undergoing mental distress. But I was also, because as she mentioned, she also talked about policies in line to be able to caution these people or to be able to have other staff aware that these are signs and symptoms or these are indicators of a mental distress from one of their colleagues. So I just wanted to inquire for our expertise. What would you, from a HR perspective or from an admin perspective in an organization, what should you look into as you even come up with that policy so that it's more informed and more in line with mental health practices, so that it doesn't just look like a policy standing there as a directive, but also a policy that is in line to that objective?
Thank you, Bridget, for that question. Now, if you've been following up with the progression of mental health within the country, sometime, I think it was early last year, the Ministry of Health actually launched guidelines to promote mental health within the work environment. There's even a document that has come out where you need to, in any work environment, form a committee. I think we have about 9 people in that committee, if I'm not wrong, from various departments to talk about what are the issues that we are likely to experience within the mental or the workplace, which can impact on the productivity of the employees and what we do about them. That document, I can share a soft copy in case but you can actually still get it on the internet. So it talks about forming a committee which looks into the issues which are likely to impact productivity of employees. And those things could be like things that they're experiencing away from the work environment, because sometimes you could be having something that is happening at home. You could be having, maybe you're taking care of a child with special needs. Then you come to the work environment, your mind is not there. You have what we call presenteeism. So you're there physically, but mentally you're very far away. How do we help that kind of an employee? Because their productivity has gone down. Maybe they've started taking alcohol or substances. What has changed? What is the HR recommendation for if an employee doesn't come to work 1 day, 2 days? Do we give them shock calls, or how do we handle this? Do we have an employee assistant program within the work environment, which is now an employer-based initiative, which takes care of things which are hindering productivity of employees? So there is actually a government document, and you can get it from the website. Just look for workplace. I forget the name, but I can share with you online. If Linda can reach out to me, I can share it with you. So to look at exactly what is required within the work environment. But you draw a committee from different departments. So even from finance, then you must have a psychologist. I think you have someone with disability. So to put your heads together, there is the guideline, but then you also know, according to the SOPs of the organization, you develop a policy which fits within that particular organization. But the baseline recommendations are there. Bridget, is that okay?
Yeah. It's very okay, Victoria. Thank you very much. I've been able now to also have a point of reference. That's actually what I actually just needed, so that you're more informed on as you're coming up with those policies. And I'm also happy you shared your number, so that's also a plus. If I do need your services or I need your expertise, I'm able to inquire.
Thank you, Bridget. You can always text me or WhatsApp me in case I don't pick up the call on voice, but you can reach me on WhatsApp or text and I'll be glad to help. Thank you.
Thank you.
All right. We still have a few more questions on the chat. Maybe we can handle one by one. Is that okay? It's already 3:10. I don't know. We'll see if we can handle most of them. So the question goes, how does Chiromo address from Nathan, how does Chiromo address the triggers for maniac episodes, even when communicated during admission, e.g. phone access and phone use, targeted to family or friends? Stay of admission, even when the patient is saying they are okay.
I'm not sure if I get the question, but if they're asking about things like phone use when we have a patient who is manic, if you look at it, when someone is experiencing a manic phase, they'll be doing things ordinarily they would not do if they were in their normal senses. So why give them access to a phone where they'll probably send messages, which are not good messages? Because we say that when they're over the episode, they feel a lot of guilt and shame over what they have done when they're in that phase. So if the phone is going to be used as something to cause them to feel guilty later on, then we talk with the family and say, let this person not have access to their phones. But of course, the clinical team, the nurses will have the number of the next of kin. So in case anything is required or is needed to help this patient, then again, we're able to reach the family. The patient is not the one who is going to conclude and say, now I'm okay, because you're the one who is the professional, you're the one who is the healthcare provider, and you're able to look at their parameters, still do another assessment and see this patient is on their way to recovery, but they're not entirely out of the woods. So you're able to say, together with the family and decide that this patient needs a little bit of care. And even after we discharge them, we still get to schedule for them outpatient sessions where they still see the psychiatrist and still see the psychologist for what we call aftercare, just to ensure that they're taking care of themselves as advised by the professionals. So where phones are concerned, we may have an issue with having them have the phones when they're having that manic episode, because it could become very disruptive where their texting or their calling is concerned when they're in that kind of a situation. Thank you, Nathan.
Okay, thank you so much. ABA has also posted their contact info for members. So in case you have any concerns, any questions, if you need help in any way, you can contact the ABA office and they'll be able to help. Yeah, so you can handle maybe 2 more questions from Elias. Can downs be triggered by dreaming, say of dead loved ones? It's possible to get a recording of this session. And maybe the last question will be very insightful presentation titled Sharing. That maybe you can handle those 2 and then we can close.
On the dreams triggering, I'm honestly not sure about that. What I know is that if you're having dreams of, dead loved ones, then maybe you may be experiencing what we call post-traumatic stress disorder. So that could be another illness altogether. I'm not really sure about the dreams. Maybe let me not comment on that one. But if you're having dreams of dead loved ones, continually, you have them over and over again, maybe it's how they died or your relationship with them, then it could also tell us that you may be having what we call post-traumatic stress disorder. It could be a different illness altogether.
Please confirm the slides will be shared to the attendees.
Yes,
Victoria,
Linda, I'll share the slides.
please share your number again.
All
Kindly.
right, okay.
Please.
Hi, I think I have a question in connection to the question that was asked. So can someone have both PTSD and bipolar, whereby they have symptoms of bipolar, they have really low lows and really high highs for periods of times, and then they also probably dream of dead loved ones, meaning that's as part of PTSD. Is that possible? And how would
Yes.
you approach that?
How would you?
How will you approach that in terms of how will you help the person, especially if they are completely in denial? Yes, they're completely in denial, and in their manic episodes, it's really bad. It's actually even longer than 2 weeks. Depressive episodes are also really long and really bad. So what advice would you give, I guess, to a caregiver
Okay, well, to a caregiver is first of all for them to arm themselves with all the information to support this person in treatment, take them to a professional, attend their sessions with them, and then support them, for example, if they're taking medication or they're going for therapy. But to the patient experience in this condition, for us, what would first of all do is if the patient is manic, and maybe it's for a longer period of time, then we have even what we call injectables, which work faster than the pills. So it's also about the regimen of treatment. If you have a patient who's not compliant as well, then we also recommend can use injectables instead of the usual pills, because sometimes you'll not take your medication again because of the stigma or because of the, humdrum, that mundane thing of always taking pills. Sometimes can get very tiresome. Even when you're having hypertension or medication you need to take on a daily basis, it can become very tiring. So we say give them the injectables, treat the symptoms, manage the symptoms, go for therapy to discuss what is causing the PTSD, because you can discuss the PTSD and you can get over it. But remember, with bipolar, it's for a life, it's lifelong treatment. But with PTSD, you can actually have the medication, you can discuss the symptoms with a psychologist, and you can actually get over the PTSD. Back to Linda.
All right, I hope that was clear. Thank you so much for everyone who attended. This recording will be sent on the social media platforms, especially on WhatsApp. So I've shared the link on the chat. Just click on the link and you're able to join the WhatsApp. The recording will be sent and also the notes. The slides, sorry about that. The slides and the recording will be sent. So join the WhatsApp group. There you'll be able to follow what's happening, the webinars that are coming. We have discounts for ABA members. We have so many things. So make sure you follow the link so that you can be able to be a beneficiary of what's going on. For our trainer today, Ms. Rika Victoria, thank you so much. We appreciate your time and your expertise, and I'm so sure you'll be able to guide us even more and more in different sessions to come. With those very many remarks, we'd like to close this webinar. And is there anyone who would like to lead us in a word of prayer?
Let's pray. Heavenly Father, thank you so much for this session. Thank you for Victoria. Thank you for all the wisdom that has been shared. For those of us that are caregivers, Lord, I pray for your grace and for your help. And for those that are going through this crisis themselves, Lord, how we pray for your healing. Thank you for a great day. And may you bless everybody who's put this together. In Jesus' name, amen.
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 Amen. Thank you.